Okay, good afternoon. We're going to get started with our final session for today, which is case reports. I want to thank every single person in this audience for staying because we have some really good talks coming up and online. We're really happy that you're joining us too. It's my pleasure to introduce Greg Maddie. It's my first time meeting him today. I find him terrifying. He asks the best questions, so I know he's going to give us the best talk today on Oxygenator Changeouts. So please welcome Greg.
Thank you, Tristan, and also happy birthday. Thank you to the directors of the program here, and Richard and Luke and many others. It's really exciting to be here with 1,000 people listening in and attending in person. The title of my talk is Oxygenator Changeouts, When and When Not To, and in full disclosure, I did not come up with that title. I believe Richard sent it to me, and my first thought was, I don't really like it because you change your oxygenator when it fails, and you don't change it when it doesn't fail. But after I thought about it, I thought it was actually quite brilliant because there are other options, and that's what we're going to talk about today. So a lot of what we're going to talk about today is in a publication that my group published in Inject in just several months ago in December. And I appreciate my team back home in Boston, shown on the slide here. We have 13 perfusionists and a couple assistants. They are covering while I am away. All right, so some people have mentioned snow, so I thought I'd show this picture. On the right is Mother's Day a few years ago in northern Vermont. I've got this small place in northern Vermont near Canada, and you could actually snowmobile on Mother's Day. It's quite different down here right now. I do have some disclosures. I don't think any of them are relevant, but I have consulted for some companies, and I also published a textbook, but I'm not a salesman. I'm not here to sell anything. And my wife and I actually donate the proceeds of that to a charity that's very important to us called the RFK Community Alliance. But I thought it was important to mention it because I'm going to come back to my book later. All right, so we've talked about a lot of really cool things at the meeting so far, and this is probably the least sexy talk so far. But I would like to talk about oxygenator failure. And before we get into that, has anyone here experienced an oxygenator failure during bypass? All right, so for those of you listening in, there's probably about 20 people that just raised their hands. This is a high-risk, low-frequency procedure that we must be familiar with. And when I think about perfusion, I like to think about the foundational knowledge of the perfusionist. And certainly, we just learned about simulation and talking about students and whatnot. If you describe what perfusion is to people that are not in our field, you basically tell them you run a heart-lung machine, and it has like a heart component, the pump, and it has a lung component, and they get it. It's a heart-lung machine. It's taken over the function of the heart and lungs. And so as perfusionists, we need to be experts in those things. If you're just talking about the basics, we need to be experts in those things. So today I'd like to talk about the oxygenator. All right, so we're going to talk about oxygenator failure. What is it? How does it typically present? What's the current textbook guidance? Again, I think this is foundational knowledge for what we do. So what is the textbook guidance? What are the options to treat it? And also, I'll share with you my institution's new and improved algorithm when we are presented with oxygenator failure in the operating theater. All right, so what is oxygenator failure? So I think most of us here know it's the inability of a membrane oxygenator to transfer sufficient oxygen. And very fortunately, unlike some other emergencies in cardiac surgery, this one usually emerges over time as decreased PaO2. Now, it can happen suddenly, but the oxygenator failure cases that I've seen and talked to others about, typically you see your PO2 just dropping over time, even after you max out your FiO2. And most often we think of oxygenator failure during bypass as being associated with fluid in the gas phase. You know, the oxygenator gas phase is leaking fluid, whether it's water or blood or serous fluid of some sort, and that decreases the gas exchange surface area, decreases efficiency, and it can lead to a problem. And there are things we can do to try to treat the wetted out oxygenator. Less often, and I'm not really going to get into this too much today, but less often oxygenator failure can be associated with clotting or cryofibrinogenation, you know, having fibrogen or platelets adhering to parts of the oxygenator or the heat exchanger in particular, high pressure excursions, that sort of thing. And when we talk about oxygenator failure, you know, how often does it happen? I was actually surprised that in this room, probably, you know, a third of the people here have seen oxygenator failure. I think that's great. You know, how often does it happen? It's really hard to know. There are some authors that I, you know, cite here, you know, 50, 100, or 50 to 150 per year. One author back in 2006 said that there was one person that died every year, either due to a ECMO or bypass oxygenator failure. But it really doesn't matter what the incidence is. As Bruce and Ed talked about with simulation, we need to be prepared for high risk, low frequency events because we're the perfusionists, we run the heart-lung machine, and frankly, no one else in the operating room can fix the oxygenator. The docs that we work with, they expect us to be experts in that area. All right, so if you agree that understanding your heart-lung machine and understanding the oxygenator or oxygenator reservoir that you use, then there must be some textbook guidance on that, right? Because there's not a ton of textbooks for cardiac surgery. I'm sorry, for cardiopulmonary bypass. And so I just selected some of the some textbooks. The first one there, cardiopulmonary bypass and mechanical circulatory support or mechanical support. A lot of people refer to that as Gravely, the Gravely textbook. The editors are changing now, and the new edition's coming out later this year. But that's a very popular book, and I think it's probably the most purchased book in the United States, at least, for perfusion education. And then I selected 2 editions of the Ghosh textbook that's based in the UK, and that's also a great textbook. It's called Cardiopulmonary Bypass. And then just for fun, I threw a surgery book in there, Saveston and Spencer's Surgery of the Chest. That is a massive 2-volume edition. It does have some information on cardiopulmonary bypass. And so what guidance do they give us on oxygenator failure for perfusionists, right? Particularly the cardiopulmonary bypass books. I was very surprised to find that there's no specific coverage of oxygenator failure or intervention options in those textbooks. I think that's fascinating. And if you look at some of the other textbooks, again, I just chose some that I'm familiar with. The cardiac anesthesia book, you know, Something from Anesthesia, that's a great book from the guys in Penn State. The Blue Book, or the Manual of Clinical Perfusion, most perfusion students buy that. Another edition of Ghosh, but with different editors. Christina Moore's Cardiopulmonary Bypass book, my book, and then the group at Columbia Medical Center. If you look at those textbooks, they discuss oxygenator failure to varying degrees, and they may even describe the process of how you do an oxygenator changeout. So I think that's really good. And if you look at this book, I just wanted to point out this book, Extracorporeal Circulation. I believe this book is used in Europe as the sole source of information for the perfusion boards. This has oxygenator failure in it, and it mentions that there's other things you can do to treat oxygenator failure, but it doesn't tell you what. All right, so I just thought that was really interesting, what textbooks are offering us for oxygenator failure, particularly cardiopulmonary bypass books for perfusion. All right, so some of our last speakers, Bruce Searles and Rob Baker mentioned, we liken perfusionists to being airline, either the pilot or something, or bypass being related to flight, takeoff, level flight, and landing. So I want to show this video. It doesn't have any sound, and I just want you to think about your role in the cardiac operating room when everything's going normal, you're in level flight, and then things may kind of get into a tricky situation, and you got to figure out how you're going to get out of that situation. And if you look at this clip, if you saw that, it was very quick, but something kind of bad happened, an emergency happened. Well, I'll call that a low frequency, high risk event. He lost his wing, okay? So I want to come back to this, but I want you to think about this as with your role in mind in the cardiac operating room. All right, so we'll come back to that. Now, we talked about the textbooks. Earlier, we talked about simulation, and oxygenator failure was one of the simulations that all the schools teach. But I also looked at the literature for oxygenator failure, and there's not a ton of literature, particularly in the last 20 years, about oxygenator failure and the various options. But this paper was published by the group up at Maine Medical Center back in 2002. And this was a brilliant paper from Bob Groom and his team up there. In this paper, they came up with this technique that we'll go over due to a bad outcome. And when I say bad outcome, it wasn't just a bad outcome for the patient. I talked to Bob about this incident years ago. It was very traumatic for the team. All right. And so they really wanted to figure out how can we prevent this traumatic event, not just for patient outcome, but for our team. And what that group, their clever solution was to build a bypass. Can you guys see my cursor? Yeah, okay. So to build a bypass loop around the primary oxygenator on every circuit. And if you did this and you had oxygenator failure, you could put your secondary oxygenator in while you're still on bypass. You don't have to come off, get this all primed up, ready to go, and then move your clamps over, and you'd be good to go. And when I saw this publication years ago, it reminded me of ECMO. I used to do ECMO over 30 years ago, and back with the Meds, we always had a diamond built around the oxygenator, and so it was a very similar concept. And the group up in Maine Medical Center started doing this when they came up with the technique, and they do it to this day. But there's not a single center that I've been to that utilizes the Pronto technique, and there are some reasons for that. One, they may not be familiar with it. I did find that out in the literature. Tim Wilcox published a paper in 2023 talking about that. Some people don't want to build something into their circuit that is going to be used at such a low frequency, and particularly pediatric centers, their circuits can get so complex with the different therapies that we're doing and the number of pumps that we're running, so they don't want to build this in. But there are other options, so we're going to go over those. So when I think about oxygenator failure, or when we think about oxygenator failure, I think the first question we have to ask is there a concern for high pressure excursion? Is something going on in the oxygenator system? Are you concerned for clots? And if you are concerned for clots, well, there's really not much you can do that's different than the current literature guidance. And so if you have those concerns for clots, you're going to have to do an oxygenator changeout, or you're going to have to do an oxygenator reservoir changeout, right? I think probably the best example of that is if you get protamine in your circuit somehow, you got to change the whole thing out. It's not going to work. There's no temporizing measure there. The other option would be an entire circuit changeout. So I'd be curious to know, has anyone in the audience here ever done an entire circuit changeout during bypass? Wow, that's more people. There's about 7 people that raised their hands. And I've only done that once in my career, and it surprised me. We had a case where we had a Terumo FX15 oxygenator, And that oxygenator has the arterial filter wrapped around the oxygenator membrane. And during a case, I was actually precepting someone, that perfusionist noticed that there was something growing on the oxygenator, and it was post-filter. And it reminded me of my ECMO days, so I was very concerned that it was fibrin formation. And I didn't know what was going on, but we discussed it as a cardiovascular team, and we decided we're just going to change out everything just to make sure that we keep our patients safe. Subsequently, we found out after the case, we sawed open the oxygenator, sent it to our pathology lab, and it was actually platelet aggregates. So maybe it would have gone away, but that's how we dealt with that. So an entire circuit changeout's exceedingly rare. But what I would like to talk about more so today is oxygenator failure that's due to membrane failure, and when you don't have concern for clots. And this is a chart that you may or may not be able to read depending on where you are in the audience. There are a lot of options to treat oxygenator failure, even though the literature guidance that we have is very limited. And the first option is the traditional option that you change out your oxygenator, which is just the oxygenator bundle, or you can change out your oxygenator reservoir system. So that's the first option. The second, and that's what most people are familiar with. The second option is the Pronto technique, and the Pronto technique is great, but you have to plan for it in advance. Now, the third option in pink here, I like to refer to it as the arterial piggyback technique, because you're using arterial line blood in some way to pre-oxygenate your venous blood. And I was not able to find the arterial piggyback in the literature, but I have talked to people for decades. I've been in perfusion for almost 30 years now. I've talked to people around the world that have done something similar to this to treat oxygenator failure. And I'll show you a picture of it later, but basically you just have a recirc limb that's after your primary oxygenator. You insert another oxygenator, you pre-oxygenate your venous blood in that way, but it's reliant upon the primary arterial head to provide flow to both devices. And there are some limitations to that. What I think is really exciting are the venous piggyback options, or the venous pre-oxygenation options that exist. And the first two listed here, you could, if you had an emergency, instead of coming off with oxygenator failure, instead of coming off for, depending on who you talk to, 2 or 3 minutes. Bruce just gave a presentation on simulation and cited a paper that him and Ed Darling published showing that oxygenator changeouts can be 6 or 7 minutes or something like that to people that don't practice it. And it can go down significantly if you do practice it. So it could be a long time. But if you use a venous technique, the two that are listed here, the two venous piggyback techniques that utilize the boot of the circuit, which goes from the reservoir to the arterial head to the oxygenator. If you cut it in on the reservoir outlet side, you can do that really quickly with a Y in some tubing. You can do that in several seconds and then go back on bypass. So that's an option. Or you can cut it in after the arterial head, again, several seconds, and then you're back on bypass. But those options have some disadvantages. And I think the most exciting option is the bottom one here, which is a venous piggyback coming off the venous line. So I'd like to look at some pictures about that. So the beautiful depiction here is of a simplified circuit schematic, how we use things at Boston Children's. So if this is our venous line coming down, our cardiotomy venous reservoir, the boot line to the arterial pump head to your primary oxygenator. We have a recirc that helps for oxygenator changeouts and priming, and the arterial limb going up to the patient. And what we always have available in our circuit is an active ultrafiltration head. And this is shown here pulling off of the venous line. Most often for our circuits, it's a stopcock, pulls off the venous line. You can go through a hemoconcentrator, send it back to the reservoir. And we set that up because we want to have, this is a pediatric program. We want to have complete control of flow through the hemoconcentrator and not just rely on system pressure. Certainly if you're doing a little neonate, you're under regional perfusion or just low flow, you don't have a lot of system pressure and you may want to take volume off quickly. This gives us ultimate control, and I think it's wise to have active filtration in every circuit. So this is our typical circuit. Now, if you have oxygenator failure, if this device fails, you have to come off bypass for 2 to 3 minutes. You have to work within the confines of the operating room, which may be constrained due to the position of the heart-lung machine in the OR. And you have to work with usually at least one other person to replace this device, okay? And that is, it can be a complex task to make sure that you get it all done, de-aired, and again, we're working with the newer oxygenators, particularly the Medtronic Fusion and the Terumo series, which have the integrated arterial filter. So you're working with connections post arterial filter. So there is some risk with that, and it requires regular practice to master, as Bruce and Ed's paper pointed out. So that's a traditional oxygenator change out. And getting back to the Pronto method, again, clever solution that the main med guys came up with. You have to have this in every one of your circuits, this loop here. And if you have oxygenator failure, well, you just put your new oxygenator in there and switch your clamps around, and you don't have to come off bypass, and that's great. But you have to have that set up on every case. So the arterial piggyback that I mentioned, this is a situation that happened to us in December of 2023. We had a 6.5 hour bypass run, or at the 6.5 hour mark, there was oxygenator failure, and we confirmed that it was oxygenator failure. And we decided that we only needed about 15 minutes of support. So we went to do the arterial piggyback. And the arterial piggyback is putting your secondary oxygenator here. You don't have to come off bypass. And you're pre-oxygenating your venous, but you're still going through your primary device. And this has a limitation because while you're going through your primary device, you probably don't want to exceed the flow rating there, right? So if you have an FX05, for example, that's rated to 1.5 liters, you don't want to exceed that because you don't know how that's going to impact GME or gaseous microemboli, or at least that's what we recommend. So this does have some limitations. And on the December 2023 oxygenator failure case, we had to partially clamp this, and it was a balance, and it wasn't a perfect balance on how much secondary oxygenator flow we needed versus primary patient flow. So the venous piggyback technique, when your primary oxygenator fails, what you can do, and for the purposes of this talk and for time, I'll show just getting rid of the hemoconcentrator here. You can just use your secondary small pump here, pump it through an oxygenator, and then go back down to the reservoir to pre-oxygenate. And I think this is really the best option. So our new intervention algorithm for oxygenator failure at Boston Children's is, if we're, we'll talk about the most common pathway here. If you're not concerned with clots, then usually the piggyback oxygenator technique is worthy of consideration. And I think everyone really should be thinking about venous oxygenation to get you through the bypass period. Now, it may not be a definitive intervention, but I think it adds a massive amount of safety. When oxygenator failure presents and the PO2 starts falling, you have to act quickly. With a venous piggyback situation, you can put that in. It'll buy you some time, 10, 20 minutes. You can think about what you're going to do. You can get everything ready. And then if needed, you can do an traditional oxygenator change out under ideal conditions. So I really think it's something that people need to think about. And just real quickly, this is our circuit, or image of our circuit, and this head is really close to the reservoir. Typically, it's just spread a little bit in this image. And this is the hemoconcentrator for active ultrafiltration. It goes back to the reservoir. And if we were to have primary oxygenator failure, we would just put in an oxygenator device right there and pre-oxygenate. So this technique here, I was really excited about. We thought this was amazing. And then we discovered, or I discovered through a literature review, that Wolfgang Botcher and his group in Berlin had actually reported on this several years ago. But I just don't think it's well appreciated that this is an option. And I think it's something that should be considered to add safety to our patients. So I'll show you the ending of this video here, reminding everyone that we have to be experts in what we do. And as perfusionists, we should know all the options, in this case, for oxygenator failure. So this guy had oxygenator failure. In his case, his wing came off. And I promise you I'm not going to show someone pass away here. So he's coming down, and then he has to think about, what can I do? What are all of the tools in my box to get out of this situation? And as he's coming down, you can see that he's oriented his craft upwards. He's using the propeller, not really the wings, for a lift, and expertly brings it in and drops it in. So I thought that was pretty cool. So in summary, perfusionists must be experts first and foremost in perfusion. You must practice oxygenator failure drills. You know, and as Bruce pointed out, practice in the publication there, practice can decrease the time to do it. I think it was 70%. It was some big number. And I really think that if you don't have the pronto in all your circuits for oxygenator failure, you should really consider venous piggyback technique. And one final disclosure for that video that I stole off of Instagram. It was a promotional ad that they did some, I don't know, special things to, but it is possible. There are planes that have landed with one wing, even fighter jets without propellers have done it. So thank you very much. These are my references, and I'd be happy to take questions, or we can wait for the panel. Thank you.
Let us get you a mic just so we can get going.
You can say that again, Perry.
So with your venous oxygenation, anything to think about, like for venting? You have suckers on high, you have your two venous drainages now. What is the limits to venting your oxygenator? Especially with pediatrics, I would think, more than adults.
You mean venting the
reservoir?
The reservoir, yeah. So hopefully it's not a situation where you're concerned about clotting. It could be a case where you're on bypass for a long time, and your cardiotomy could be getting near the end of its life. But I don't think that would really come up if you have a port available. You know, we have a singular port, and it's usually a 1/4-inch port on most devices, and that's more than enough to handle massive sucker flow. So I think a little bit of extra flow from the oxygenator would not impact venting. Great question, though. Thank you.
Any additional questions? I have just one. Since you were able to do additional oxygen supplementation through your recirc line and then also your venous technique, did you notice any difference in the PO2s?
Yeah, so our group has not utilized the venous piggyback technique clinically yet. The group out of Berlin, Wolfgang Botcher's group, they have done it. I don't recall what the PO2s were for that, but on the arterial piggyback situation that we were in with the FX05, we had PO2s that were falling below 100, and we knew they were going down at a pretty good rate, and we were able to stabilize the PO2s greater than 200. and get off bypass within, I can't remember if it was 20 or 30 minutes.
We've used that at Stanford as well.
Yeah.
I'll ask one question, which is, do you think that this should be taught at all perfusion schools as to how you should change an oxygenator, or the options of how you should change out an oxygenator, not just the one way?
Absolutely. I think it's massively underappreciated that even though there is a method, the gold standard is oxygenator changeout, there's a lot of risk involved. And I mentioned Tim Wilcox because he's from New Zealand. He published a paper in 2023, and in his paper, he cited that there were reports of people that had oxygenator failure in their adult practice who did not change their oxygenator because they were worried about the risk, and they had periods of marked hypoxemia. And it's very terrifying when you have when you have to do an oxygenator changeout in the confines of the operating room. I think that the venous technique in particular can be so easy to implement. It gives everyone time to all get on the same page, and it's not as much of an emergency. So my hope is that I'm going to inspire people like Suni and other program directors to think about other options to get the patient safely through that emergency.
There we go, recommendation for the PPDC.
Yes. Thank you very much.